So I'd like to start with a case. This is a patient who had angina, had an end-STEMI in the past, and a positive PET scan, came for PCI because you can see the diffusely diseased LAD. Baseline FFR was 0.55, and using IVUS guidance, I put in 2 stents there, and I did a repeat measurement after those 2, and the FFR was 7.1. So a lot better. We've gone from 5.5 to 7.1, but still not yet 1, and we might ask, why is that? As Dr. Lee was mentioning, there's been a very large collaboration that we've done over the last 2 years or so, looking at what happens after PCI using modern drug-eluting stents. And as you can see here, in well over 5,000 vessels, the FFR value is a continuous number, tells you not only what happens to target vessel failure after the next 2 years, but even hard endpoints of cardiac death or target vessel myocardial infarction. So the FFR at the end of the case is really what associates with prognosis over the next 2 years. Interestingly enough, coronary physiology is almost like a meritocracy. It doesn't matter where you start from, it just matters where you end up. You can see in this other analysis that's done by our group in many thousands of vessels, all of the clinical parameters don't tell you about target vessel. The FFR value that you started with doesn't tell you about target vessel failure. It's the final FFR value at the end of the case. So the higher is better, and all of the other things actually fall out once you make those FFR measurements at the end. So this was an editorial that my colleague Pim Tonino and I wrote several years ago, asking this question, and why is the FFR at the end of the procedure not always 1? And we decided to group things into 4 different mechanisms, and I'd like to go through those with you now. It turns out that the key to understanding which one of these mechanisms, or sometimes you have more than one at the same time, is going on, is the pullback curve. The pullback technique is something that's so fundamental. You've been hearing about it from Dr. Lee and some of the other metrics that have been developed for it, but it's been something that's around for a long time. All the way back in 1996, Nico Piles was talking about using pullback curves, and as you can see, really that lays bare the problems in the artery. When we do these pullback curves, while there are quantitative techniques for it, conceptually what we're looking for are 2 different patterns. On the left-hand side, focal disease, where you just move the sensor a few millimeters and it jumps quite a lot, as you saw in the case here from Astra Med City that we were showing you earlier. And then the second pattern is where there's very diffuse pressure loss along the vessel. So let's go through these mechanisms one by one and talk a little bit about them in the data. The first one I'd like to talk about is pressure drift. This is a technical artifact of the wire, and the solution to solving this is to re-equalize and go back down and measure again. It's some of the hard data is this graph that I'm showing here that we did as part of the contrast study using the Eris wire, so a generation or 2 ago in terms of pressure wires. But you can see, like everything in the world, there's a distribution. The most common or average value is basically 1. So on average, you don't have any drift, but perhaps your pressure wire isn't average, right? So about half of the measurements are within 1 point of drift, about 80% within 3 points of drift, and over 90% within 5 points of drift. But you can see even this very large series, values as low as 0.8 per drift and as high as 1.07. The second mechanism is there might be a second lesion in the vessel that either was not appreciated or is part of a tandem or serial lesion set. And so this is the kind of unmasking that usually leads to the largest gains in FFR with further PCI. Now, take this LAD as an example. You can see on the initial pullback, it looked as if lesion A was the much more important one with the largest pressure drop. After that lesion was stented, the vessel was remeasured. And now you can see that what used to be a relatively small pressure jump over lesion B has become larger because you've increased proximal flow through the lesion A, and that's then gone further up on the pressure loss flow curve. Diffuse disease is a challenge, and you heard Dr. Lee discussing some of the options and techniques we have for anticipating it. But once you finish treating the focal disease in the vessel, usually what you're left with is diffuse disease. And so in some ways, most often what FFR represents after PCI is an objective quantitative measure of diffuse disease burden, because PCI has largely removed the focal disease. Diffuse disease is frustratingly common. This is probably one of the first large series that brought it to our attention. You can see this case example of a man who has stable angina, FFR of 7.6, with very diffuse pressure gradient up and down this lumpy, bumpy LAD. And some of the statistics on the right show how common this is, even in patients who have a vessel that's not considered focal for PCI, that low FFRs from diffuse disease are common. The other reason that I'll put into this category is that actually the LAD has lower FFRs because it has higher flow because of its larger mass. So the amount of flow down a blood vessel relates to the mass of the downstream myocardium multiplied by the perfusion, right? So in some ways, this is like cardiac output equals, body surface area times cardiac index. And the LAD supplies more mass than the other territories. And for that reason, its absolute flow is higher, as you can see in the blue rows in the table. And because the absolute flow is what determines the pressure gradient, average FFRs in the LAD are more like 9.9, whereas in the circumflex and RCA, it's more like 9.6, 9.7. And so you can see in this cohort of 25 patients who had completely normal coronary arteries, had CT angiograms, and there was no coronary atherosclerosis. You can see patients all the way down to 0.88 in that series. So really, it's quite uncommon to get LADs that have a final FFR value that's much higher than 0.90. The final components, of course, and this is why I think a conference like this that brings together imaging and physiology is so good, is that the stent itself causes gradients. And so untreated segments, as well as all of the other mechanisms that you can see here on this particular slide, are ones that are due to procedural technique that can lead to low post-PCI FFRs. And that's probably the area for using imaging for stent-guided optimization as well as strategy placement at the start. Can you use the FFR value then to improve it using imaging techniques like OCT or combined physiology imaging as in the target trial? It's quite humbling how modest those gains are. You can see that it's just a few points on FFR. So well, I think there's a bit of a disconnect there. The issue is that I think imaging-guided PCI may improve clinical endpoints, even despite very modest increases in FFR. And the reason to understand that, I think, can be explained by this recent data that we've been putting together. And you can see up towards the higher end, where in many cases end up PCI values with an FFR somewhere around 8.5 at the end. Let's say you take that 8.5 and you made it 9.0 by doing imaging-guided optimization. You can see the relatively flat portion of the curves that you're on, and that's why trials need to be fairly large in order to understand if this is a clinically significant benefit. Probably is, but I just bring up that we're not on the very steep left-hand side of the curve. I'll just finish up with 2 slides. This is talking about another ongoing randomized trial in this area called FFR React. It's a study of about 640 patients who will have post-PCI measured at the end of the case. If the final FFR value is less than 90, then they go into randomization between HDI, IVUS-guided optimization versus no additional intervention. And the primary endpoint then is a death, target vessel MI, or vascularization after 1 year. As you can see, some of the lesions will have high FFR values, so they'll just stay the same. And their estimate is around 300 or so of the patients will have low FFRs and go into this other category. I guess for me, the thing about this design is if you took this patient off the table with an FFR of 8.5 and brought them back a month later and measured the 8.5 FFR, you wouldn't do anything about it, right? So why should we be doing something in the acute setting? And I think that's some of the questions that the FFR React trial will help us to understand. Although, as you can see, the types of event rates that would be expected suggest that maybe this sample size will not be sufficient to give a very definitive answer. So to come back to the case I started off with, this was a patient who I'd already done 2 stents in the LAD and just kind of did an interim FFR measurement. You can see that there was a focal jump over that proximal segment, not too surprising. You can even see it on angiography. Put 1 more stent in there and the final FFR was 8.1, which I think is reasonable given the amount of diffuse disease as well as the fact that it's an LAD, and so you rarely get much above 0.90. Thank you so much.